So the Pacific trial data is perhaps one of the most exciting pieces of data that we've seen in the stage 3 locally advanced sphere for a long time. And this is patients who have had chemotherapy and radiation and who have not progressed after chemotherapy and radiation, who are then restaged, and within 42 days they're randomly assigned 2-to-1 to durvalumab, which is an anti-PD-L1 monoclonal antibody, or placebo. So this is a blinded study, and then followed for 2 primary endpoints, one of which is progression-free survival, and we have that data, and the other one is overall survival. So we have just heard the progression-free survival data today, and there's a large advantage for the durvalumab arm. These patients had a median progression-free survival of 16.8 months compared to only 5.6 months for the placebo arm. So I want to emphasize that all of these patients had chemo radiation, as we've just discussed, and then subsequently. So this is a kind of a maintenance treatment for up to 1 year of the durvalumab or the placebo. In terms of the tolerability of this seems to be very well tolerated. There's a small excess of side effects which are consistent with what we know about durvalumab, but it seems overall to be very, very well tolerated. The fear factor that was there before was that would there be an increase in radiation pneumonitis is only slight and has not really materialized. There did not seem to be an increase in treatment-related deaths as a result of the active treatment. And so overall, I think from a safety point of view, this is very acceptable. From a treatment efficacy point of view, it's very exciting with the increase in progression-free survival, and also an increase in the response rate, which is obviously assessing the lesion that has been irradiated. So this is not a clean RECIST type of non-irradiated assessment that we would like, but this is what we've got, of course, because the purpose of chemoradiation is to radiate all of the known disease. So in terms of the response rate, that's all we have to go by, and these patients are unresected, so we can at least monitor the lesion. And the response rate went up from about 16 to about 28% on the durvalumab arm. So there's more tumor shrinkage as a result of going on the durva arm. There are fewer distant failures, as well as fewer deaths. This is an interim analysis. I want to emphasize that. There will be further analyses to follow. 2 co-primary endpoints, PFS and overall survival. At this point, we don't have the overall survival data, so I won't talk about it at this point, but we do have very, very encouraging progression-free survival after 371 events, with a delta of 11 months, as I say, going up from 5.6 to 16.8 months. It's difficult to believe that this isn't going to move the needle as far as survival is concerned down the road. So I would hope and I would expect that there may be a positive survival benefit as a result of this, but I want to emphasize that at this point we don't know that for a fact. And the question really is, do we have enough information now to change our practice at this point, or do we need to wait for survival? It's an important question for us. I think we're obligated to inform our patients of this result. This result is now in the public domain. Patients may be aware of it, and whether they are or whether they aren't, we're now obliged to tell our patients that this information is out there. It shows a large positive benefit for progression-free survival in patients such as them with very acceptable toxicity. So I think this would be very attractive for the average patient. The question is going to be, can they access it or not? And we're always in this dilemma. Do we tell people about exciting treatments that may not yet be funded and they might not be able to access? I mean, this is a bit of an ethical dilemma, but I think the world has come down on the side of transparency and telling patients about the truth. So I think we're obliged to inform patients that this is a fact. Going forward, I think this progression-free survival is unlikely to change. So far we have 371 events, which was the trigger for the interim analysis. The final progression analysis will be, I think, up to nearly 500 events, but basically most of them have happened, that are going to happen. So I think this progression-free survival is unlikely to change as we get to the final analysis of PFS. I think it's also important to tell patients, however, that at this point we don't know for sure the effects on survival. But I think many of the patients ask us, Doc, what do you think this is going to be, how's this going to affect my survival prospects? And I think we have to be honest and say that probably it's going to benefit survival, but we don't know that for a fact. And I think that's what we have to say to patients. But on the other hand, I think we can say this is relatively safe. although there's a theoretical risk of autoimmune side effects and immune-related side effects which are well known. Most of them appear to be manageable. We understand them at this point. And so from a safety point of view, I think the safety is acceptable. The progression-free survival is very real, very large, very different from what we've had over the last 20 years. And you know, the sort of question that I'm often asked is, well, if it was you, what would you do? And the answer is, I'd opt to have it if I could get it on what I know now. But of course, you know, we have to wait for the regulatory process to unfold, and we have to know whether or not there's going to be access programs and so on.